Well, hello and welcome to today's webinar, a family-centered research agenda for supporting caregivers of children with special health care needs. Next slide. My name is Ryan Collar. I'm a pediatrician at the University of Wisconsin-Madison and the UW Health Kids American Family Children's Hospital. I'm thrilled and honored to have the privilege to be moderating today's engaging discussion. We are recording this webinar and it will be available on the LPFCH website in the coming weeks. Next slide. Joining me today are three distinguished experts: Clarissa Hoover, Project Director at Family Voices; Renee Turchi, Chair of Pediatrics and Pediatrician-in-Chief at St. Christopher's Hospital for Children and Drexel University; and Debbie Harris, System Specialist at Family Voices in Minnesota. As you've seen in their biographies, each member of today's panel has unique and specific expertise in the subject matter for today's webinar. As lead author of the article behind today's discussion, Clarissa will help orient us to the critical topic. Next, Renee and Debbie will provide highly insightful and thought-provoking clinical and family perspectives. Following this discussion, I'll be back to moderate a dynamic question and answer session. Next slide. We are offering live captioning for this webinar. You can access the captions by selecting the closed captioning button at the bottom of your Zoom screen, or click the link in the chat to view captions. If you're having any technical issues, please enter them into the Q&A and we'll try to assist you. Next slide. Ask questions. We want this to be an engaging conversation and encourage all attendees to submit questions in the Q&A box. We'll try to get to as many as we can today. Next slide. To orient us to how we got to today's webinar, I'll first share a brief background. Today's webinar dives deeper into one section of the National Health System's research agenda for children and youth with special healthcare needs. This research agenda was developed as part of a 5-year cooperative agreement with the Maternal and Child Health Bureau's Health Resources and Services Administration. The purpose behind a national research agenda began with acknowledging that key outcomes have proved stubborn for this population, and that despite having a large volume of research output, as well as guiding material such as the MCHB core outcomes and the standards for systems of care for children and youth with special health care needs led by AMCHIP, or the Association of Maternal and Child Health Programs, and NASHP, the National Academy for State Health Policy. The promise for having a national research agenda is that it will complement these efforts by both shining the spotlight on family priorities and coalescing stakeholders around a cohesive set of health systems research priorities. Next slide. The framework for the National Research Agenda began in 2018, and it was developed through engaging hundreds of stakeholders over a series of complementary processes, including contributions of open-ended ideas, a robust prioritization method called the RAND UCLA Appropriateness Method, and subsequent stakeholder focus groups. This background was published in 2020, and now a refined and in-depth summary of each of the 6 key research areas is being published as a series of articles in Academic Pediatrics with support from HRSA MCHB and the Lucille Packard Foundation for Children's Health. Each article summarizes key knowledge gaps and recommendations for future research in one of the 6 topic areas. A webinar in December discussed youth to adult healthcare transitions, and today we're discussing the second of these topics, caregiving at home. Additional topics will be discussed in future webinars. And with that, I'll turn it over to those who you really want to hear from, beginning first with Clarissa Hoover.
Thank you very much, Ryan. So I wanted to start by talking about how we conceptualize caregiving for this research agenda. We are focused on children and youth with special health care needs. In terms of the expertise on this webinar, we're a little more focused within the medical complexity subset of that larger definition, but we are really thinking about all children who have special health care needs. And a really key distinction that we want to make is between the idea of caregivers and who caregivers are and what they need, and the work of caregiving as an activity that contributes to the well-being of children and youth with special health care needs. So we wanted to have everybody thinking about the fact that caregivers are to caregiving as doctors are to medicine. There's really 2 different areas. and the National Research Agenda addresses these two topics separately. Types of caregiving include family caregiving, which may be either paid or unpaid, often unpaid, professional caregiving that happens in the home health setting, and institutional caregiving or professional caregiving that happens in institutional settings. Next slide, please. So for today's topic, we're not really talking about caregiving, professional caregiving in institutional settings. We're focused on home health, including family caregiving, unpaid and paid, and to some extent professional caregiving that is provided within the home. Next slide, please. So I mentioned that we're thinking about caregivers and caregiving as two separate things. I just wanted to do a brief discussion about the article on caregivers and family support and family health that expresses caregiver burden is not a phrase that we prefer on the whole. Caregiving and caregiver work is a labor of love. It's parenting, it's family love. It's not that different from parenting or family care that happens for other children, other than the intensity and difficulty that it presents. The article on caregivers has a resiliency orientation. So we're focusing on the resilience that families bring to their situations, how they contribute to their own health and improvement, and the needs of the family in general. That's another version of sort of a strength-based orientation that we're focusing specifically on this topic of resiliency. It's thinking about caregiver support as an opportunity for emotional support, an opportunity to recognize the special needs that caregivers have because they are caregivers. And that is an area that definitely overlaps with what we're going to be talking about for the rest of this session, because caregiver support can address caregivers' personal needs, or it can address their caregiving related needs, their work related needs. If we're going to conflate those two different kinds of support into the same kind of interventions, we need to keep in mind that it is two different things. The emotional needs that caregivers have because they are caregivers, and the work that caregivers do because they love their children. And then finally, one of the things that is a big interest is thinking about how caregiver health and sibling health and other family member health impact the health outcomes of children and youth with special health care needs. So this, again, distinguishing caregiver health from caregiver work, both very important, but we want to be keeping in mind, especially when we're doing research, that they're not exactly the same thing. There are different issues involved. Next slide, please. And so for the remainder of this presentation, I'm going to be focusing on the caregiving paper, not the caregiver paper. These are the two questions that were generated in the research agenda process that Ryan described earlier. How can the optimal level of home supports, including home health care, that a family needs be to improve child and family outcomes be determined and achieved? And how does rurality uniquely affect children and youth with special healthcare needs? And what are effective interventions to support them and their families living in rural settings? Next slide, please. So in order to respond to these research questions, I want to start out with a general recommendation. One of the reviewers in the article called us on the fact that this wasn't completely clear. And so I'm making it very clear now. In the article, it's in bold, and in the presentation, it gets its own slide. All of the projects from the CSHCN research agenda and the projects suggested in from our paper and from projects suggested in other articles in the supplement should be carried out working with youth and family partners and with the intent of being family driven. Family engagement, youth engagement, community engagement is going to be an essential component of how all of these things come to be and how they're successful at our goals. Next slide, please. So in terms of our recommendations for how to respond to the 2 research agenda questions on caregiving, our first research concept was to develop a conceptual model of caregiving that acknowledges the volume and sophistication of connections and resources needed to care for children with special health care needs at home. And so in order to start thinking about what a conceptual model of this kind would look like, I'm taking a personal example. Eleanor's my daughter. You see pictures of her there when she was maybe 4 years old, and then when she was a new driver at the age of 16. And she's now approaching graduation. So who takes care of Eleanor? Herself about 1.5 hours a day. Her father every day. She's currently living in his house full time, so he takes the brunt of it. His mother her mother most days, even though she's not living in my household right now. Her boyfriend most days. All of those numbers are related to healthcare only. I'm not talking about general care or love or friendship or anything. She sees a therapist once a week. She sees her teachers, of course, most days, and they spend time thinking about her health needs pretty often as well. She has a care coordinator specific to her healthcare needs, who I would guess probably needs to work on issues relating to her about once a month. And all other healthcare providers combined or individually would be every 3 months or less. So that includes the rest of the team of specialists who deal with her healthcare condition and home health and other needs of that nature that she has. Eleanor does meet the definition for medical complexity, no matter what definition you look at, but she's kind of on the edge of that. Like, I'd have to look at each individual definition and say, yes, I guess that does apply. In a little bit here, we'll be hearing from Debbie, whose son is so much more complex than Eleanor that it's really just a kind of different world relative to what our experience is. So that was our first research idea, and that's just a little bit of thinking about what that conceptual model might look like. Next slide, please. So our second research suggestion in order to respond to the research questions was to do social network analysis to quantify the relationships and paths of the conceptual model introduced on the previous slide, uncovering relative contributions of model elements on key health outcomes. So here again, I wanted to share an example. This again is our example. What do violin lessons have to do with health? The violin teacher wasn't listed on the previous slide because Eleanor's not taking violin lessons anymore, but for much of the last 15 years, she would have been in that list of weekly contributions to Eleanor's health. So these are some of the ways that she contributes. She gives us a chance to be normal, undertake normal activities. It's hard to explain how important that is to people who aren't necessarily experiencing sort of unusual needs every single day, but it's really meaningful to us. Working through medical trauma. If you see this little guy in the photo here, he's obviously a beginning violinist. If there was a teacher there, she would have her hands all over him. She'd be straightening him up. She'd be repositioning his hands and repositioning his violin. And when Eleanor first started taking violin lessons, every single time somebody smiled and reached for her, she would like visibly cringe and shrink away because friendly people who reach for you are going to hurt you in her world. Just the number of shots and other procedures that she'd had, you know, over the years of doing violin lessons, she learned that happy people are helping you, which I think probably also extends back to accepting some of the things that she's going through in the healthcare realm. Mandatory socializing, a reason to get out of the house. Again, it's hard to express how important that is in the lifestyle that we're living. You'll have to take my word for it. And I think Debbie's going to illustrate that very well. a weekly consultation when we were in violin lessons. The violin teacher was the only person who was sitting down with me every week to talk about Eleanor's development and needs. And so when I say that she was a healthcare provider, like that's, it was just really, really important to have her input and have her help. And then finally, having a task that is challenging without being life-threatening, and learning to enjoy striving for something rather than everything being so fraught and rigid in terms of what their requirements are. Next slide, please. So our third recommendation in terms of responding to the research agenda is to do randomized controlled trials. And this is recommending this method and applying it in a lot of different ways, particularly as relates to health equity. So to go back to what the paper says again, approaches for remedying health inequities by supporting the work of diverse family caregivers need backing from a strong evidence base. So that is what the randomized controlled trials are there for. Not just to answer the big questions that apply to everybody, but to answer the questions that are incredibly important to smaller groups of people, to subsets of the community. So what does the evidence say? Here's an example of some of the questions that as a family caregiver I would have. You know, what does it mean to me? What does it mean for where I live, for my race, for my rare genetic condition, for my work schedule, for all of the things that make things work out a little bit differently from me, from how they work in sort of the idealized or average situation? Does the evidence answer the questions that I have? Does it really matter whether it's TID or QAH? Q8H, those are pharmacist abbreviations. TID means 3 times a day, and Q8H means every 8 hours. A lot of people writing prescriptions might consider those to be interchangeable. In an institutional setting, they are. Either way, it's going to be happening every 8 hours. If you start a dose at 4 o'clock in the afternoon in the hospital on the first day you're there, they're going to be waking you up at midnight every single day to give you the dose that's 8 hours after 4 hours. And then they're going to be coming to you again to give you the next dose 8 hours after that. The entire time you're there. At home, we don't necessarily do that. If it's 3 times a day, then it's when you get up in the morning. It's when the kid gets in the car after school. You know, first thing I do is hand in the dose. Second thing I do is say, hey, how was your day? And then right before bedtime. That's not too different from every 8 hours, but it's a little bit different, and it makes a big difference versus I give her a dose when she goes to bed. I take an hour of me time, and then I go to bed and have to get up again less than 8 hours later in order to wake her up, in order to give her her dose. And then I fill out all of the forms in order to get like a 2 o'clock dose an hour before school gets out. Trying to go through that very quickly, but I hope I'm kind of painting the picture of how big a difference that small change makes. And so the last kind of question I have for the evidence is, are we choosing questions that are easier to answer over questions that need answers? Are the limitations of research driving what research questions we're asking? Or is the idea of trying to benefit everybody rather than benefiting people who are experiencing health inequities and really need the answers driving our questions? And if we find that the tail is wagging the dog rather than the need for answers pushing what research can do, how can we push the envelope to make sure that those questions really are getting answered with solid evidence base? Next slide, please. And with that said, I am going to hand over to Renee. Thank you very much for your time.
Thanks, Clarissa. My name is Renee Turchi. I'm really thrilled to be here today. So to transition from that wonderful talk that Clarissa gave, really framing the work that we did, I wanted to talk from the healthcare provider perspective. My favorite days of the week in my world are the days that I get to see patients in my practice. And one of the things in doing some of this work that I've reflected a lot on, and for many of you that are in the healthcare sector, you might think about this a bit. In the course of my day of seeing patients, I am often very aware of who's at the front desk, or my medical assistants and my nurses. But if I don't have folks registering patients, helping me administer vaccines or immune globulin, or weighing and measuring patients, or helping me with some of the care coordination activities, I'm not able to see patients. I'm not in a position to take on multiple roles within my practice. I don't even know how to register a patient. And I don't even have access to that in my electronic healthcare record. I don't have access to order certain things that our nurses do or administer. So I can't even take on those roles. And I think it's an important caveat, if you go to the next slide, as I think about what we are talking about with caregivers and the caregiving and the great analogy that Clarissa presented, when we think about often when I see parents in practice, and I think about some of the children with medical complexity, and I think about the first time I might meet a parent of a new patient that I'm seeing who's coming out of, let's say, the NICU, and might have a feeding tube, a gastrostomy tube, or might have oxygen, or might even be on a ventilator with a tracheostomy. One of the things that I often say to parents is that in many ways, we sprinkle pixie dust on you, and we give you a couple of weeks of training in the hospital. Sometimes I have a great dialogue with parents about whether some of them times they'll say to me, I had no interest in ever wanting to do anything medical. I would have been a nurse if that's what I wanted to do. But here we find ourselves where many of our parents are becoming the caregiver and doing the caregiving because they love their children and they'll do whatever is needed. But when we think about that and all the roles that we think about in practice and the amount of training and schooling, and it's all by choice at the outset, the situation that sometimes our caregivers find themselves in. In the next slide, really, as I think a lot about, caregivers and our children and our youth with special health care needs and medical complexity, and we think about them living in their home and they get discharged to home. And then as we move along, our caregivers are now taking on the roles of many times physicians, nurses. I recently said to a parent, you've trained more tracheostomies than I have in 20 years of being a pediatrician. So they're taking on these caregiving roles, as also often, working very closely with home care agencies, sometimes filling in for the home care agencies. If, let's say, they have a home care nurse who is called out or unable to come. They're also managers. So they're managing schedules. They have phones. They have phones and numbers that might just be very dedicated to managing a staff in their house, managing multiple nurses. They have calendars and they're managing schedules of not just their own and their family, but of multiple therapists, of people coming in and out of the house. They often also, you can keep going through, they find themselves also in situations when I think about the recent pandemic where we pivoted to virtual. So we had children and youth that were receiving physical therapy, occupational therapy, speech therapy. Well, now it's Zoom. And so now we've had parents in the home now becoming physical therapists. And so often I've had parents talk to me about and caregivers, how they are finding themselves, doing maneuvers and things they're not trained to do. And often it's very intimidating to be on a screen, assuming the function of a therapist. They're also managing medications, refills, getting prior authorizations, thinking about, do they have the equipment needed to administer those medications? They then can find themselves, when I think about the virtual world, when with COVID and without, some of our families are homeschooling, whether they're homebound or they're virtual, and assuming, all that might have been in an individualized education plan. They're also thinking about medical equipment, understanding medical equipment in a realm, where I often think about, for some of our families, their living rooms or their houses have become mini ICUs, intensive care units, where they have whole hosts of medical equipment. They have setups. Families will talk to me about drawers that they've set up, plastic containers, how to store 30, feeding bags that are coming every month. And sometimes the equipment's incorrect. And so they have to think about excess or not enough. Thinking about transportation, where, maybe they have to either convert their own vehicle or think about, if they don't have that as an option, how they are going to get to appointments, to school, to participate in family events and be part of their communities. And also just thinking that, many of our families, as Clarissa so astutely pointed out, thinking about siblings. It may often not only be the only child that has special healthcare needs or has chronic medical complexity. So it might be managing extended family or other needs that arise in a family. And we layer all that on. We think about the COVID pandemic. So COVID has come, and think about all that going on. And now we have a pandemic where maybe your shift of nurses can't come, or maybe you don't necessarily want nurses in who you don't know if they're vaccinated, or you can't control that, or you don't know if they're tested. And now you're having someone in your home, or maybe they're calling out and you can't get to your job. But the difference is, when I think about our staff in the hospital and they call out, or I go on vacation, I have paid time off. Our caregivers and don't have that. So when they are, I think about many of our family members during the pandemic, they were at times finding themselves doing 24-hour-a-day care, which is something that would never happen in a hospital setting. You can go to the next slide. In the article, one of the figures that I think is really very poignant to me, that kind of really underscores a lot of what Clarissa so eloquently talked about, is this framework. It's figure 2 in our article, and it really conceptualizes the healthcare services and research based on whether they are family-centered, system-centered, neither, or both. And if you focus your attention in that bottom right-hand corner where it's family-driven is circled there in red, that really is the best qualities of the family and system-centeredness. And it really means that our families have primary decision-making capacity and roles in the care of their children. And this really also includes the procedures, the policies, the relationships, anything governing that care for their child. And that family-driven approach in research really focuses on the needs and the goals of the family as the driving force that's shaping the healthcare system and the family caregiving of the child that we're all caring for. So I really like this figure, and I think it drives home a really important point about family-driven care as we think about the research agenda. You can go to the next slide. So I wanted to just talk a little bit about, as we think about the research and this relationship that we think about families, home health, and the healthcare systems. And really this conceptual model for us as we think about in the paper that hopefully you can either see or review, really is we're talking about reframing. We're looking at things holistically. And, part of that in the research agenda is understanding, acknowledging, and honoring, the caregiver work. And I think it's really important just to underscore a point that Clarissa really made, is kind of really taking away that idea of caregiver as a burden. And thinking about goal setting and care mapping, and really thinking that, we want to understand that family-driven approach, focusing on research where we look at, the resilience that families are, responding to the role that they have on their child's health, and looking at research that also looks at the relationship between families and the various home health, other partners and systems that are needed to help care for their children. And when we think about the assessment and measurement, some of the things that are mentioned in the article, as Clarissa mentioned, are things like technology and telehealth, thinking about things as that relates to inequity or equality. So thinking about the digital divide and thinking about that rapid pivot to telehealth that we all saw during the pandemic. And when we think about technology, really addressing that issue of rurality that Clarissa pointed out, and thinking about technology and telehealth, and ensuring that it's equitable, that it's adaptable, and that it's effective. It's not just enough to give, a family, a power pack for internet and not really understanding what it would do, and sort of really thinking about access to care, distance to tertiary care center, access to services for our children, youth, and families that are living in rural areas. Also thinking about transitions. And when we talk about transitions, I really think that it's important that we underscore that we're talking about transition from hospital to home, from adult to adult oriented systems, and the transitions of care that occur, transitions in insurance, transitions of agencies. There's a lot of transitioning that occurs in the caregiver experience. And also we think, and we talk a little bit about this, the health related quality of life that exists for the child, and the trust that's needed for better relationships between family, caregivers, and healthcare professionals. And also, as was previously mentioned, the social networking and that social network analysis. And, there's a whole pedagogy of research done on this, where we really look at children and families and all of the social networking that is related to how caregivers support each other, as well as within the system. And I think what's so important is thinking about woven into the fabric of all of this research, the honoring of the cultural and ethnic diversity, and that health equity has to be present, omnipresent, at every step. And we have to think about the entire population of children, youth, and special healthcare needs, and think about things like race, ethnicity, income, geographic, thinking about rurality, urban areas, the social determinants of health, and remembering that children, youth, with special healthcare needs are not defined by their healthcare conditions alone. And so thinking about, those outcomes with that lens, and ensuring that the impact of the social determinants of health are addressed and considered in the research. You can go to the next slide. So I say to you, as I kind of close my comments here, that really, as I kind of think about our caregivers, really thinking about this reframing. We talk a little bit in the article about the invisibility. And so I would say to you, think about caregivers as very much visible. Think about them as part of the healthcare workforce, the experts in their child's care, and really forming meaningful research partnerships that make them holistic and really represent the life of the caregiver and their families. And with that, I'd like to turn it over to my colleague, Debbie. Thank you.
Hi, everyone. I'm Debbie Harris, and I am here to kind of show you the real-time version of caregiving. Our son Joshua has complex medical needs. There have been times where we thought perhaps we were going to kind of have an easy road for a while as he became more stable, but it's always up and down, kind of complexity, a roller coaster of events, and they don't seem to stop. So please, next slide, please. So this is Josh, and I want you all to meet him. This was when he was an infant. I know that ICU looks very antiquated to most of you, but that's what it looked like when Josh was there. And he was in that first little stall as you came through the NICU door. And that was reserved for the sickest babies, even though at the time, at about 3.5 pounds, he was probably the biggest baby in the NICU. Next slide, please. This is Josh now. Well, actually, the photo in the upper right-hand corner is Josh right now. The bottom one with Josh and myself, that was taken a little bit of time ago. And then the photo where he's at his physical therapy session was, of course, before the pandemic. But we have an amazing physical therapist who's actually been with Joshua since he was 6 months old. So well over 20 years. And she comes to the house now to see him. But in those times where he could go there, it shows how he really developed in his ability to kind of coordinate his body a bit. There's nothing holding him, no strings or anything attached. Next slide, please. So this is the sign on your left that we have up as you come to our door. And this was actually before the pandemic, but we just wanted everyone to know why we have certain rules and conditions before you come into our home, because while something might seem just mild and kind of not relevant to most of us, Josh, just having some exposure to a person with an illness can end up in the hospital in the ICU. That's Joshua. This past week, he got a new planetarium projector for his birthday, which was January 10th. And he loves it, and he just loves to stare at those colorful stars. As a matter of fact, so do I. So I love to sit down there in Josh's room with him, and we listen to stories and watch the stars. Josh also, you can't really see it there, but he has an iPad, and he loves to watch the news of all things on his iPad. It's something that came about when my father, who passed away in 2018, would actually come to help us take care of Josh. And he came every evening for 5 evenings in a row during the week. And he was Josh's person. And so they would watch the news together. And so even though we call him Papa is gone now, Josh still likes to do that. And I think it gives him a sense of place and security and safety. So that's Josh's room. And the meds on the right, just kind of to remind me to note that so many of the things that we kind of take for granted that we do, I don't know if others realize what has to go into it. And there are times where you have like all of the meds memorized in your head, but you, no matter how long you've been doing this, you still have to check. And it takes about 45 minutes in the morning to draw up Josh's meds. He's got about 8 pages of meds. Some are PRNs, but he does get those 3 times a day, Clarissa, TID. Some of them are still Q8 hours though, so it makes it kind of difficult. Next slide, please. So this again is Josh's room. We actually purchased a mini air purifier because we have so many different people coming into our home looking after Josh in one way or another. So that is by his bed. We also have an air purifier a little bigger over by the nurse's chair. And then we had to install one on our furnace to try to get rid of as many microbes as we can to try to keep Josh well. Josh is on a ventilator at least 8 hours a day. Yesterday, he was just not wanting to really wake up, and reminded me of that song, Today I Just Don't Want to Do Anything. I just want to stay in my bed. So that's what he wanted to do yesterday. And he just loved being on his vent for 8 hours and was also on through the night as well. It does make it a little bit more difficult during these times because we're being rationed for the tubing that goes with the ventilators. We're being rationed regarding gloves for our staff, and we have to have someone watching Josh, awake care, 24 hours a day. And our DME company is now only allowing 3 boxes of gloves per month. So we have to purchase those on our own. And now that's Josh. Next to that, in his tub, we did have our home remodeled to have a walk-in, but Josh actually kind of he zip lines in from the ceiling and we drop him down there, and he has a special seat that we had our seat people at our hospital. We tie him in there and then right there, give him bubble baths with Whirlpool, and it's really wonderful for his muscles. Next slide, please. So those are Josh's meds. And as you can see, there are a lot. In the top drawer are his respiratory meds. You don't see those. My husband is the person who loves spreadsheets and Excel. And so he has an actual spreadsheet that he keeps track of all the medications, all of the physicians for each medication, when they were last ordered, and when they have to be ordered again. He also has a spreadsheet, as you can see, that little clipboard on the left. He keeps track of the schedule for family members who we are kind of Josh's PCAs. We're the people we trust, and we don't want to have necessarily just strangers coming and going. But Josh does have orders for 24-hour nursing, but it's very difficult to get that right now. But we do have nursing care as well. And so everyone reports their availability to my husband once a month, and he comes out with those schedules, and we all know who's doing the day shift, the evening shift, the night shift. So, and we're Josh's constant backup. So for example, last night and the night before, it's my husband doing the night shift, my son doing the night shift, our older son who has his own family and a full-time job doing the evening shifts. And then I often do the day shifts. So nursing is very hard to come by these days. And so you have to kind of make it as competitive as possible. And so that is like the nursing area on your right, where we have a mini refrigerator. We also keep Josh's refrigerated meds there, and a microwave and a toaster and a coffee pot, because it's almost a marketing, it's almost a marketing plan that you have to draw nurses into your home now. On the bottom to the left is where Josh's elevator is coming into our downstairs family room, because it was very difficult. As you can see on the right, there's a platform lift that was coming down the stairs, but Josh's wheelchair weighs about 189 pounds. He weighs 100 pounds, and just trying to maneuver the chair and Josh in the little, you can't see it, but there's like a little tiny foyer area there, to get him on and off the chair is extremely difficult and takes a lot of strength. And we knew as we were getting older, we'd have to have some alternative. Also, that lift, the platform lift, it's probably broken down. We've lost count, probably 15 times over the past 15 years. And the last time the power supply failed right when I was underneath it, and it just came right down on my head. But the middle picture is what is really important to me, because that is kind of like entering into the nursing area. When we first saw this home, which was quite a long time ago, we went down that hallway and we saw to the right, there's this huge storage area, and to the left, a nice huge area for nursing staff. And we thought, this is the house for us. So because it met Josh's needs, because previously we were storing Josh's supplies and equipment underneath the stairs in our tiny home and in our garage. Next slide, please. So like I said before, one time we went for, a few months where Josh, he had no hospitalizations, he had no surgeries, and we probably had great nursing staffing. And I was thinking we were on easy street. And so I remember saying, because he got very, very ill after that and ended up in the PICU, in the PIC, the Pediatric Intensive Care Unit. And I remember saying to one of our favorite physicians, I thought we were done. I thought we were done with the hard stuff. And he said, Debbie, you won't ever be done. And, I couldn't see that far ahead and know that, as he grows and as we get older, there are always going to be difficult times. The photo to the right is just this fall. Josh had pancreatitis, pulmonary edema, a pulmonary effusion, colitis, and I can't even remember what else, but he ended up in the ICU in an adult hospital. It was our first time transitioning to an adult medical system where we didn't know anyone. But I will say that our complex care clinic and the physicians in the ICU there coordinated so amazingly that it really made the whole thing survivable for us. And because they were in constant communication with one another regarding Joshua, it helped a very difficult time, and probably not as great, not a very great prognosis, turn into something completely different. The photo in the middle is when Josh got home from the ICU, and all the time in the hospital, he didn't open his eyes, he didn't wake up, he didn't react to us. As soon as we got him downstairs and we said, Josh, you have to go out to the family room while we completely strip down your room and disinfect everything. The nurse and I were doing that. Josh just opened we turned on the TV, he opened his eyes and he started watching his news. So it was like an amazing experience, even though it was a difficult one. And the other, I know Clarissa had mentioned about the health of caregivers. And I just show that photo because in full disclosure, I have chronic and acute anemias. And so I have to visit my hematologist every 3 weeks, and then again every 3 months for possible infusions. So under what others might consider the burden of caregiving, it's not really a burden. It's just the different life of caregiving, you have to also deal with the aspects of regular life as well. And sometimes I just feel like I'm barely hanging on, but still have to manage all the aspects of Josh's care. Next slide, please. So self-care is the topic that comes up. And I remember years ago, our pastor said to me, Debbie, I want you to just really concentrate on keeping up with your flute playing, keeping up with your writing. And at the time, things were so chaotic and so difficult in our lives in every way, with nursing staffing, with Josh's illnesses, with so many surgeries. At one point, my husband was activated to the, he was in the Marine Corps for 33 years, and he was deployed. So he was gone to Kuwait and Iraq for cumulatively 3 years. And at the time, they took our nursing away because that was before companies were allowing troops to keep their civilian benefits. And I had to pay Cobra a couple $1,000s a month just to keep one nurse. And she was amazing for us, but I had to kind of ration the nights that she came. So for a couple years, she came 2 nights a week, and I did 24 hours a day other than those 2 nights a week. So self-care is essential. In this photo, I will tell you, I took my can of Microban and I just escaped from the house, and I ran off to the most expensive hotel in St. Paul and stayed there for 3 days. So it was amazing. So next slide, please. That never happens, by the way. That would never happen. So the other aspect of caregiving, I don't know if everyone is aware of, is that I mentioned earlier, for example, we get 3 boxes of gloves from our DME paid for by insurance. So what I have to do is I have to subscribe to get other supplies. And so this is just an example for, so for the gloves, like I might be paying about $80 a month to get the extra gloves that we need, because we have several caregivers, including ourselves. We have peri-cares, we have trach cares, we have gastrostomy care, we have bed baths, suctioning. All these things require you to have gloves, and there's no way that 3 boxes are going to do. So we have to purchase these things. The CareWell receipt is for additional incontinence wipes. So that's another almost $100 a month. And then we only get a very limited number of Chuck's pads. So we have to add that on. So I don't know. I think it's good to be aware of the expenses families take on just to get through having like this kind of mini hospital in your home, and just the very basic and vital things you need to take care of your child. We do have a waiver that reimburses for these, but there's a lot of turnover in case management in our waiver plan. And sometimes it's to get reimbursed for these things. It's like trying to find your way to the city of Oz and approaching the Wizard of Oz in the Emerald City to convince them that you should indeed be reimbursed. And the ad kind of toward the in the middle is just to show the competition, the dire need for home care nursing. An agency here is advertising $10,000 sign-on bonus to do night shifts and $7,500 for day shifts. So that's how scarce home care nursing is. Next slide, please. So we have safe spaces in our home. Sometimes I look at social media, I look at people on Facebook going on vacations, on Instagram. Their lives look so amazing and perfect, and they are so mobile, and it does kind of like burden my heart a little bit if I start to feel sorry for myself, but I really can't go to that place. So what we do here, if anybody starts kind of like saying, I really need a vacation, we just say, look out the window. Like, so we have to take the small blessings that we have. So we have this tiny lake outside of Josh's window, and just look out the window and look at nature. And once in a while, you'll see some bunnies or a deer or a coyote or something pass by. In the middle is to the right of that is the space where I'm actually sitting right now, is where we made an extra spot for Josh so that you can barely see it, but there's a lift up there a ceiling lift, so that we could have Josh in our room when we have a number of nights or shifts that aren't covered by nursing, and then we don't have to go way down in the lower part of the house away from everyone. We can bring Josh upstairs, and it also gives us another space to change him, so he doesn't have to just be taken away from the rest of the family to meet all of his needs. So I actually put that in there when my husband was deployed so that I could make it through those several years. And then there's the little lake again. And then my she shed on the right, it took me 20 years to get everybody out of that room so I could finally have a room of my own. And Josh now loves to go in there with me and watch his news, and I can shut the door and pretend like we have no medical needs in our home and it's just us in there hanging out together. And so that's one of our safe spaces. Next slide, please. We have a lot of people in our lives who have helped us make this journey. And on the left, I just want to say that one of the things that started us off successfully was having a physician specialist who believed in us. And when we were facing terrible biases, and people would just speak them out right in front of us, in front of him. And when I saw him go to bat for us and stick up for us and say, no, that's not right. You know, you can't make those assumptions about this family. It made me feel valued. It made me feel like Josh was valued. And we have had extremely blessed relationships with Josh's physicians, some who have been with us since our oldest son, Nick, you can see him smiling there in the next picture, was born. And so as we would watch them retire, I would just cry and I would just weep. I didn't want to see them go, but what they left us with was an amazing gift of advocacy and feeling worthwhile. And even though Josh has disabilities and complex medical needs, just see him, they saw him as Josh and appreciated him for the contributions that he makes and what he can do. That's myself and our three boys. In the next photo, one of our son, our oldest son, has his own family, and that's our little grandson Bentley there making faces. I often told Josh that I started volunteering as soon as I left my job, which was I had a full-time job so I could carry the insurance. My husband was a systems application developer at the time, and so he was on contract. So I carried the insurance, but it just was too much of a burden. No, that was a burden for me. And so I did start volunteering as soon as I left my job as a tech writer. And I often would say to Josh, if you want to see mom at any time, then you're just going to have to sign up for a panel with me. So that's Josh and myself on a panel together, participating as a team. We have a van for Josh that he loves to just go for rides and look out the window. It's also a safe space because he doesn't have to, right now during the pandemic, he doesn't have to interact with others, but still gets a little bit of time out of the house. But families do, even though there are resources to get the lifts and accommodations for vans, you still have to buy the van yourself. So that's a lot. And we are grateful for all the associations we've made over the years. And Josh started out there with Minnesota Vikings. I'm sure they're all retired by now. But anyway, we've got to meet lots of amazing people throughout this journey. So it has been a blessing in many ways as well. Next slide, please. So these are Josh's people. John, the other day, we had to get Josh to a doctor's appointment. It was about 17 below here in Minnesota. Josh's van lift froze open, and our son John there had to carry him out of his van and into the house. We have amazing nurses who have been with us for going on 7 years now. And the ladies up in the top photo we call ourselves ordinary moms of extraordinary boys. We used to try to meet at a restaurant every now and then when we could all manage our schedules, but now we meet on Zoom every Monday, and all of our boys are about the same age, and we discuss their needs, and they are really my people because they really understand. So thank you. I think that's the last slide.
Thank you so much.
Thank you so much.
Debbie. I think strong encouragement to read through the chat at the many extremely positive and thoughtful notices of thanks for you sharing so generously your experience and really bringing it home to all of us. I think I speak for many that they would love to go and get their doctorate with you as their teacher, given the wealth of knowledge that you've acquired and experience. So thank you all to the panelists. Please share any questions in the Q&A box. We will try to get through a couple questions in the last few minutes here, and I think stay on a little bit longer for folks who have the time. I'll go ahead and ask the first question. I direct it towards Clarissa and Debbie, if you can weigh in, please. When thinking about supporting family caregivers, I think a lot of the tendency is to focus on folks who are maybe new to the role of caregivers, perhaps a new diagnosis, a new circumstance in the lives of a family. Can you talk through whether you think there are issues that are specific to folks who are in that new role compared to folks who are maybe actually extremely seasoned caregivers and have been caregiving for a long time, whether that distinction is important, and what are some of the unique needs of caregivers who are really experienced, and what research should sort of do to account for the spectrum? Clarissa, if you want to get us started.
Yeah, and of course, the first thing that comes to mind is self-care. It never gets easy. It never gets automatic. To remember that the caregivers have need as well as the child with special health care needs and the other children in the family. And I guess what I would say is that my daughter's specialists for a while had an annual family day where they would like give new research or stuff like that. And there was an element of just like, it didn't even necessarily matter that much what we were talking about. It just helped me get out of a rut. And, you know, there are things that I'd learned to accept, that it was like reminding me to not necessarily just go with that particular flow, or just get a fresh perspective on you know, routines that can get very very familiar. I mean, you know, it's like you don't think about brushing your teeth every day. You don't think about doing your airway clearance every day. It's in a way not necessarily healthy to not make it too conscious that you're doing what you're doing or that what you're doing is different. But there are times when you have to take a step back and say, you know, how can we make this better? How can we, you know, do we need to be doing all of this? Could we be doing less? Or, you know, just whatever is going to help that way. Debbie.
Debbie, you're muted.
Yeah, sorry. So I remember when Josh had made a milestone in the NICU and was almost ready to go home before he kind of regressed again. And we were happy about it. And we didn't know what we didn't know. And so I remember kind of like just being kind of rejoicing in that moment. And one of the residents came to me and said, do you think you're just going to take him home and everything's going to be fine? Well, it's not. And then she began to kind of let me know all the things that we could expect over the years if Josh survived. And I remember just completely having a breakdown and having to call my parents to the hospital because it was too much for me to take in what might happen later on. I couldn't take it in. And so I have since learned to take life 20 minutes at a time. I know a lot of you have heard me say that. And that's what the advice I would give. Just like be in the moment, handle the challenge, handle the joy, take life 20 minutes at a time. And that's how you get through it. Not even a day at a time, 20 minutes in our case. Thank you.
Thanks, Debbie.
Mm-hmm.
One of the questions in the chat was, how do families navigate services when the hospital portal or the electronic medical information becomes the medical home? And I think the spirit of the question is essentially, how do families learn to navigate through all of the different information streams when they may not have a lot of simplicity, feasibility to sort of access that information? There may not be connections across the different services that they need if it's sort of living in a siloed place like the health record. And Renee, I can put you on the spot first as a person who works closely with the health record, but I would invite everyone to weigh in as well.
Yeah, you're directing this at me, right, Ryan?
You got it.
Okay, sorry. One of the things that I think is really been great now, if some of the new legislation is that families have access to health records, like kind of the care everywhere. So I think one of the things that's really helpful when I think back to, early on in my career, dating myself, but when we didn't even have electronic health records, where we were doing all these different things where families had memory sticks and taking pictures of care plans or paper care plans. But now I do think that having families have access to their medical records in real time across systems, and even for those of us in healthcare systems, so that we're not relying on families completely to be the conduits of information. I think though that, helping families understand, it's more than just saying, from the healthcare perspective, especially a newer family, helping them understand, how do you access the portal? What does that mean? If you're traversing systems, how do you let folks know that it's there? How do you see things? What do you do with that information? The other thing that I would say too, that I often will talk about with families is, sometimes actually getting access to the information without the context of a clinician can also be very overwhelming. Like you're looking at labs and you see all these things out of range, and that can be very anxiety provoking. So I would say that, the era of the electronic health record can be a really great support to families. But in addition, I think when I think about the home health that we talked a little bit here, and some of it we talked about in the paper, I think that's a whole other arena in terms of the care integration that's needed across those systems. I think the question was very specifically about electronic health records, but I think that that's just one snapshot. When you think about, families as the epicenter and what's needed to go to the education system, to the therapy system, to home health care agencies, I think that the care integration, care coordination part is really at the heart of it all. I'd be really interested in Clarissa and Debbie's thoughts.
I'd like to just say a couple things about that. I love that you noticed that there are so many aspects to the need for records. And for example, our home healthcare agency doesn't have an electronic system. As a matter of fact, they pick up the flow sheets, which they also use as the employees' time cards. And they pick them up so often that we have no record in the home at all of Josh's condition, his trends, his vitals, nothing. So I actually had to write up a recommendation, a proposal on how they could implement an electronic system that wouldn't be very costly and use that with families. So right now, what we do is we just keep a giant whiteboard and we keep all the vital information that we have to keep track of on the whiteboard. There are ways, I think, for families who don't have access to maybe use email to keep track of goals and so forth. They do an excellent job of that with our complex care clinic. But it is a lot to navigate and to go through. For example, we have case management through our military insurance, case manager for the waiver, case management through our medical system. So we have a lot of different organizations to coordinate, and none of them are cohesive electronically. So.
Clarissa, I'll point the next question towards you to start, because this came up a few times in your comments. There was a question in the chat. When should self-care support for caregivers be introduced? Should folks wait for them to ask for support? Could you speak to that?
No, don't wait. It might never happen. I think probably the best way to handle that is in sort of a continuous fashion. Like, don't, and Debbie, I'd be grateful to hear what you think about this too, but to don't push. Like, there might be times when thinking about self-care is actually making things more stressful, but to kind of continuously bring it up. Our team has a social worker who comes in and asks us every single time, how are you guys doing? What's going on with you? There might be times when it's sort of apparent that it might be appropriate to push a little harder. Like if a parent is visibly shaking or having trouble talking or something like that. Just to be aware of what a person is doing. I mean, it's like I'm already seeing a therapist, I've got my own ways of kind of handling that, identify the cases where people aren't really doing what they need to be doing for themselves, and know what support they consider to be important, like whether it's church or a really strong extended family. There's a lot of variability in how people are doing that. So just because they aren't doing it the way you think they should doesn't mean that they don't have it covered.
I think self-care has been a difficult thing for me. I have a hard time saying no to anyone, and including my extended family. So before the pandemic, because our house is accessible, I have a brother with MS. It's difficult for him to get from home to home. And so it's easier for us to keep Josh here. I end up having all of the big family occasions at my house. But I remember I was so worn down and not feeling well. And so one of our physicians wrote a prescription or wrote an order that said we could not have Thanksgiving at our house because of Josh's condition. And I could use that to let my family know that I couldn't participate. So just being aware of the individual and unique ways that families need help means that you have to kind of get to know them and their lives. And I know it takes extra time to do that. And there's not always that opportunity, but.
That's a perfect place for us to unfortunately bring this to a close. I think we could have a multiple day workshop on this topic, and simply seeing the chat, one of the most enjoyable things for me was watching all of the different roles and professions and personal backgrounds that are shared with the rest of us. This is a great community, and nothing could better endorse how important this topic is to continue to explore in a very rich and robust way. So I want to thank all of the panelists, encourage everyone to visit the Lucille Packard Foundation for Children's Health website to learn more about the foundation's work with children with special healthcare needs and access additional resources. Again, thank you, my colleagues, for an extraordinary discussion. And thank you all for joining us today. We hope you found the discussion informative, and have a great day, everyone. Take care.
Thank you.